everyone, this is Keisha again. So this is part 2 of the videos for rhythm analysis. And so in the first video I talked about the different sinus rhythms. So normal sinus, sinus bradycardia, sinus tachycardia. And then we talked about the different AV blocks, which remember are the issues with the PR interval. Issues with your PR, you think AV block. And so this video I'm going to move on and I'm going to talk about junctional rhythms, and then atrial fibrillation, atrial flutter, and then I'm going to throw in there how to assess for a bundle branch block, which is a different kind of block than an AV block. So to start out, I'm going to draw out a rhythm, and we're going to start to go through our steps again. So as we're going through, nice and regular, right? We could use our method again where we make the dashes and move it along to find that the QRSs march out. So we have regularity with our rhythm. And we get to our second step and oh shoot, we don't have P waves, right? There's no P wave in front of any QRS. So we can't measure the PR, can't go on. Our QRS is nice and normal, less than 0.12. But our sticking point, our issue is we have no P waves. And so that starts to get you thinking that it's not sinus, something's going on. And so what this rhythm is junctional rhythm. So junctional rhythm means the impulse is not originating in the SA node like it does with sinus rhythm. And so if I draw out our heart again, and these are our atria, and here's our ventricles. SA node is up here, and when it comes from the SA node and the atria depolarizes and that conduction follows the conduction pathway, we have a normal sinus rhythm. In junctional, the SA node has failed us. Okay, so the junctional node picks up and takes over as kind of like a temporary pacer. It's gonna take over, and so it's a recovery rhythm. It's saving the heart. So it'll start out the impulse down here, and then send it right down the normal conduction pathway, down the bundle of His, out the Purkinje fibers, and then that's why we then get the ventricle depolarization of our QRS. The thing with junctional is the normal rate is going to be 40 to 60 beats per minute. As you might remember from that first video, there's different normal rates for where the impulse originates in the heart. If it comes from the SA node, then our rate is 60 to 100. If it's coming from the junctional, 40 to 60, and then if that fails and it comes from the ventricle, we have 20 to 40. Okay? And so the junctional rate normal is going to be 40 to 60 beats per minute. What we do for this is we assess their tolerance, but really we're just, most of the time we just monitor. Typically patients are asymptomatic. If they are symptomatic because of the low heart rate, we can give atropine, but you definitely, something to remember with this is you don't want to cardiovert them out of this, because this is a recovery rhythm. This is the heart's way of, it's a protective rhythm. It's that the SA node has failed, but the junctional node has picked up. And so don't cardiovert them. Maybe give atropine if needed, but really you just usually monitor. So with junctional, there can be just plain old junctional rhythm, which is 40 to 60 beats per minute. If it's faster, if it's, let's say, 60 to 100, then that's going to be accelerated junctional. again, just assessing their tolerance. Typically, if that heart rate is a little bit higher, they're going to be even more tolerant of it. And then if it gets greater than 100, we would call it junctional tachycardia. And then we treat it just like we would sinus tachycardia if they're not tolerating that higher heart rate. So those are our junctional rhythms. So with junctional, there's either no P wave, or another thing, kind of throw you for a loop sometimes, is it can be an inverted P wave. So no P wave or inverted P wave indicates junctional. I'll draw out a quick junctional rhythm that's with inverted. So what that would look like is something like that. So as you're going through your method of analysis, you would, find it's regular, and then you get to your P waves, and you note, yes, there's P waves, but there's something off with them, and that they're inverted, and that should trigger that it's junctional. So that's junctional rhythm. And so now I'm going to move on to the atrial dysrhythmias. So the first one that I'm going to talk about is atrial fibrillation, which is going to look and this one you might be alerted to at your very first step of your rhythm analysis. So you're going through, is the rhythm regular or irregular? Atrial fibrillation is always irregular. And that's because the atria are not necessarily contracting for you to give you a P wave. There are no discernible P waves with AFib. We always say in cardiac ICU that if you're trying to talk yourself into a P wave, it probably isn't one. And you're looking at, is it either junctional, is it atrial fibrillation, but it's probably not sinus rhythm. So with atrial fib, there's no discernible P wave. So there's no way to measure there's no way to measure a PR interval because there's no P wave. It's irregular, and it looks very squiggly, and it's fibrillatory waves that how it's depicted. So this is atrial fibrillation. There's no effective contraction of the atria that's going on. It's essentially they're quivering, and then the ventricles are kind of left to its own device to contract as it sees necessary. So the ventricle is not going to be regular because it's not regulated by a nice pacing impulse that comes from an SA node or a junctional node. So that's why it's irregular. With atrial fibrillation, the treatment, it depends on what the ventricular rate is, what the patient's tolerance is, but it always includes anticoagulation. So I'll talk about the actual rhythm treatment in a second, but first, and one of the most important things to remember is that these patients need to be anticoagulated. And why that is because, as I said, these atria are just quivering. There's no effective contraction to pump the blood through like it needs to. And so the blood is pooling. There's stasis of the blood. And anytime there's stasis, blood is going to coagulate. And clots are going to form. And then that really increases that patient's risk of stroke, because those clots can embolize and go to the brain and cause a stroke. So atrial fibrillation they need anticoagulation. Usually Coumadin, warfarin, that's one of the most common ones that they use. There's a lot of new drugs on the market, but Coumadin is the most common. So on to the actual rhythm. We can treat it with a variety of things. Amiodarone is probably what we see most in the inpatient setting. Also, a calcium channel blocker like diltiazem could be used. And what we want to do is at least get the ventricular rate under control. If the ventricular rate gets too fast, and you may hear it called atrial fibrillation with rapid ventricular response or AFib with RVR, those patients, they have high, so the heart rate's over 100, sometimes over 150 beats per minute, and there's not enough filling time. There's not enough diastole, and so there isn't an effective cardiac output happening during that time. And so we need to give some medications to control the rate. With atrial fibrillation, we can also do a cardioversion, and that's essentially shocking the heart, and to hopefully stop, shock it, and then hopefully it'll stop it for a second and hopefully get it into a normal rhythm again. It's almost like it's an abrupt halt to that fibrillatory, chaotic rhythm and kind of reset the heart to get it into a normal rhythm. So cardioversion is something that you'll see done a lot in the ICU, and also done in the ER as well. We can do it with light sedation, Versed, fentanyl, but we always have anesthesia available in the physician, and it's a pretty controlled thing, but can be done electively, and oftentimes it works. So that's atrial fibrillation. So think irregular, no discernible P waves. It's going to look squiggly and fibrillatory with normal QRSs. They're just irregular. Okay, on to the next atrial dysrhythmia. This is one of my favorite ones to draw because it's atrial flutter. And so this one has a sawtooth appearance. This is one you might be able to see it a couple times and just recognize it, possibly without even going through your steps, because it's so distinct in that it looks pretty dang similar to this. It has a sawtooth appearance. It can be fairly regular, maybe a little irregular. P waves, kind of. The atria are essentially depolarizing, but for when you start to go down the rest of your steps, you can't measure a PR interval. Your QRS looks okay, but it's still not a normal contraction from an impulse coming from the atria through the ventricle, etc. Atrial flutter is often seen with atrial fibrillation. They can flip back and forth. If it's on its own, it's fairly benign, but we watch it and will anticoagulate with atrial flutter as well. Sometimes they will cardiovert the patients in atrial flutter as well. So that is it for the atrial dysrhythmias. So atrial flutter, think sawtooth appearance of those P waves. Okay, and then one last note for this video is I just want to talk about bundle branch block. So this can be seen really with any rhythm. You can see it with sinus rhythm, you see sinus bradycardia, you see it with a variety. And so what we'll see is your rhythm can be regular, depending on what your underlying rhythm is. Let's say it's normal sinus rhythm. Your rhythm will be regular. You will have P waves for every QRS. PR interval looks fine. It's that there's an issue with your QRS. You get down to this step, and you go to measure your QRS, and you see that it's wide. Okay, it's longer, it's greater than 0.12 seconds. That indicates a bundle branch block. Okay, and so this wide QRS indicates that there's a block in the bundle of His. So I'll draw another little picture, which hopefully makes sense. Here's our heart. Our impulse is originating up here in the atria. It travels down. It even gets down to the ventricle just fine, so you have, your nice PR interval, that's normal. It's that once it gets down here, and it's traveling along the bundle of His, which is along the septum between the ventricles, there's a blockage. And so the QRS is really the time that it takes for the impulse to get kind of through that bundle of His, out through the Purkinje fibers, and it tells the ventricle to contract. The ventricle depolarizes. If there's a block, it's going to take more time, right? There's longer time that it's going to take if there's a blockage in that pathway. So blockage in the bundle of His is a bundle branch block, and it's depicted by simply a wide QRS that's greater than 0.12 seconds. And that can be seen with any rhythm. With that, we just kind of watch. If it's a new bundle branch block, then we're thinking, is there myocardial ischemia? Is it a sign of an MI? And so we would want to further evaluate it with maybe a 12-lead EKG if it was a new bundle branch block. People can have bundle branch blocks and live with them forever, and they're benign, though. But if it's new, we want to investigate it. So in this video, I talked about junctional dysrhythmias. I talked about atrial dysrhythmias, and then ended with the bundle branch block. And so that's it for this video. Thanks.